So for this afternoon, my topic is in management of medical complications in patient therapeutic care. And our learning objectives would be to identify and manage the sum with child with hypothermia, hypoglycemia, dehydration, and shock. First of all, I would like to emphasize on this. If clinical assessment is delayed for any reason and the child is able to take oral fluids, give 10% sugar water. And how would you do that? We prepare by mixing 10 grams or 1 tablespoon of sugar in 100 ml of water. So to start, severely malnourished children are prone to hypothermia, where the body's core temperature drops below the required temperature for normal functions. And this is defined as axillary temperature below 35 degrees Celsius and rectal temperature of less than 35.5 degrees Celsius. And between the two, the more reliable is the rectal temperature. And when you have hypothermia, always check for hypoglycemia. Why? Because hypothermia in malnourished children often suggests coexisting hypoglycemia or serious infection. So how do we treat and prevent hypothermia? First, we should always keep them warm by putting the child on mother's bare chest, covering the child, promptly doing diaper or nappy changes, prevent droughts, avoid exposure to prolonged medical examinations, and increasing the room temperature with a heater or lamp placed nearby. Then next, we feed them. Why do we feed them? Reduced mean temperature in malnourished children may be an adaptation to conserve calories, and that severe hypothermia in malnutrition results from an acute shortage of energy reserves. Frequent feeding of malnourished children is most important in their management. So we start feeding as soon as possible within 2 to 3 hours. We continue breastfeeding. For those over 6 months to 60 months old, feed with F75 every 30 minutes, as it was emphasized in the earlier lecture. Continue feeding through day and night. And if they cannot feed during the night, we consider inserting an NG T-tube. So it says in the previous slide, feed every 30 minutes for 2 hours. So how do we do this? For example, if you have a patient with 6 kilograms, calculate F75 starter feeds as follows. 6 kilograms times 11 here is equal to 66. So in 2 hours, there are how many 30 minutes? There are 4. So 66 divided by 4 is 16.5 ml. Give the 16.5 ml every 30 minutes for 2 hours. And then after that, we give, in the next hour, we give the succeeding. Basta in a day, we have to complete 130 ml per kilogram. And of course, we give antibiotics. So this is just a review of the previous lecture you had. We start with ampicillin and gentamicin. The gentamicin is given for 7 days and the ampicillin only for 2 days. If we see improvement or if patient is already able to feed, we shift them to amoxicillin to be able to complete 5 days. And then, if, for example, we don't see any improvement in the patient after maybe 48 hours, if the patient deteriorates within 24 hours, we add ceftriaxone. Now, again, everything here that we are telling you or giving you are just guidelines. Okay, we still have to consider the resistance patterns in our institution. We have to be aware of our antibiogram. Okay, and of course, we treat other infections as appropriate. If meningitis is suspected, do lumbar puncture. If you identify any other specific infections, give antibiotics as appropriate, add anti-malarial. TB is common, but anti-TB treatment should be given only if TB is diagnosed or strongly suspected. Treat HIV-exposed children as recommended. Now, I would like to emphasize on this part. Monitor, and reassess your patient. Go back to them. Well, basically in the ICU, we do an hourly monitoring. But if the child is in the wards, we can at least monitor them every 2 hours until the temperature rises to more than 36.5 degrees Celsius. And of course, we always do everything you can to keep the child warm. Okay? Now next, we will discuss hypoglycemia. All severely malnourished children are at the risk of developing hypoglycemia or low blood sugar level defined as less than 3 millimole per liter or less than 54 milligrams per deciliter, which can rapidly lead to death if not treated. Typically, children are also hypothermic, as I have already mentioned in the discussion of hypothermia. Typically, hypothermic patients are hypoglycemic. So, hypoglycemic patient can also be hypothermic. Okay. What is the reason? What could probably be the reason for this? As what was mentioned, this may be an adaptation to conserve calories due to acute shortage of energy reserves. Hypoglycemia may be caused by a serious systemic infection or can occur when a malnourished child has not been fed for at least 4 to 6 hours. And other signs of hypoglycemia, it's all here, lethargy, limpness, and loss of consciousness. There would be convulsions. However, sweating and pallor may not occur. Sometimes the only sign before death is drowsiness. Be aware and suspect hypoglycemia whenever there is vomiting, long intervals without food, waiting for admission, or irregular feeding. So how do we treat hypoglycemia? If the child is conscious, we give 50 ml bolus of 10% glucose or sucrose solution orally or by NGT tube. The sucrose solution, this is difficult because it's very difficult to find sucrose. So at least the glucose here is the one that is readily available. Okay, feed F75 every 30 minutes, as what was again told you a while ago. Keep the child warm and give antibiotics. But if the child is lethargic, unconscious, or convulsing, we give 10% glucose at a dose of 5 ml per kilogram body weight and 50 ml by NGT to prevent rebound hypoglycemia. May also use sucrose solution. However, if the child will receive IVF for shock, it's okay not to give any more than 50 ml by NGT. Why? Because when the child is in shock, the fluid that you're going to use there later on would be D5 containing already. Okay, I will explain that further in the next few slides. And of course, we give them F75 every 30 minutes. We keep the child warm and we give antibiotics. All malnourished children with suspected hypoglycemia should be treated with broad-spectrum antibiotics for serious infection. Why? Because the immune response to infections, which are common in malnourished children, uses up glucose. So we monitor hypoglycemia. If the initial blood glucose was low, repeat the measurement. If blood glucose falls to less than 3 millimole per liter, repeat again the 10% glucose or oral sugar solution. If the rectal temperature falls to less than 35.5 degrees Celsius, or if the level of consciousness deteriorates, repeat blood sugar test and treat accordingly. So how do we prevent hypoglycemia? Basically, the underlying causes for the development of hypoglycemia in children with severe malnutrition are many. But the short-term and most common cause is lack of food. Okay, so we really need to feed them. Feed frequently every 3 hours, including waking the child during the night. If unable to feed and monitor the child, the feeding, if for example you're giving them every 2 hours, we could prolong the interval, but we add the number of prolong the interval and add in the frequency. Ganun yan. After hypothermia and hypoglycemia, for our last topic, di ba, maiksi lang lecture ko, would be dehydration and shock. Children with severe acute malnutrition may have difficulty keeping themselves properly hydrated. However, it can be difficult to assess the hydration status of severely malnourished children because regardless of hydration status, the signs of dehydration are present, like the typical non-elastic skin and sunken eyeballs. So how do we identify them? Well, we go back to our favorite since med school, history taking and physical examination. So in our history taking, we determine recent fluid loss from acute diarrhea or vomiting. Elicit how well and how frequent the child has voided, particularly in the last 6 hours. And if they are voiding, we ask about the color of the urine, whether it's diluted or very concentrated. Remember, misdiagnosis and mistreatment of dehydration is the most common cause of death in children with SAM. Next, we check the physical examination. We check for their level of consciousness. The skin pinch test is very much unreliable in marasmic patient because this is typically positive for this test. As for the sunken eyeballs, we confirm this finding by asking them if this only occurred lately, because marasmic children can have sunken eyeballs due to the loss of fat behind the eyeball, or we can ask them, is it just recent or mas naging malalim na ba yung mata nila? Absent are the usually visible and full superficial veins on the head, neck, and limbs. We palpate and check if the liver is enlarged. Check for the extremities. Isang hawak lang dyan sa kamay ng bata. Marami ka nang makukuha. You can already get how cold they are. Check for their pulse rate. Check for their CRT. Isang hawak lang yun. And we check for the temperature, blood pressure, and of course, the weight. Weight here is very important, especially when we are already hydrating them. Kasi this would be one of the way we can monitor the malnourished child later on when we are already hydrating them. It's the weight. A diagnosis of dehydration should always be a provisional diagnosis. The response to treatment must be observed before the diagnosis can be confirmed. And when the following are present, we assume that there is hypovolemic shock when there is decreased level of consciousness plus any of the following: cold extremities, slow capillary refill in the nail beds longer than 3 seconds, fast or weak, absent radial femoral pulses. For children 2 to 12 months, pulse rate greater than 160 per minute, and for children 1 to 5 years old, pulse rate greater than 140 per minute. I said assume because confirmation of hypovolemic shock is by observing response to treatment. How about dehydration with nutritional edema? Well, these children cannot be dehydrated. Basically, they are overhydrated, but the fluids are not in the right compartment. Hence, they are hypovolemic. So that is the right term for patients with nutritional edema, hypovolemic. Why is it that they are hypovolemic? Well, children with kwashiorkor usually have insufficient protein intake resulting to hypoproteinemia and low plasma oncotic pressure. Hence, there would be decrease in the intravascular fluid resulting to decrease in blood volume. So, mababang protein, syempre there would be decrease in oncotic pressure, decrease yung force na nagpupull inside the intravascular space. Now, we go to the management. Children who are under 5 years of age with severe acute malnutrition who present with some dehydration or severe dehydration but who are not shocked should be rehydrated slowly, either orally or by nasogastric tube. IV infusions are only for the unconscious child and for resuscitation from shock. Okay, I repeat, if the gut, as what was mentioned by Dr. Cardinal a while ago, if the gut is pwede, we use them. If the gut is available, we use them. So IV infusions is a no-no for a child who are able to take fluids orally or by NGT. Remember, children with SAM usually have reduced cardiac contractility and renal function. Okay, so if we give them the usual hydration, they might not be able to compensate for increased intravascular volume, which may lead to heart failure. Okay, so syempre, if you give more sa preload and the patient have reduced cardiac contractility, they might not be able to handle it. So instead of saving the patient, the child, we might push them into their demise that might lead to heart failure. So ingat lang sa fluids. Treatment of a child with nutritional edema, it's different. Kasi nga, these kids, this patient, doesn't have, actually are not really dehydrated, but they are only hypovolemic. So we treat them as having septic shock, and different from what is done for a child with wasting. So what fluid do we use? This is the next question, and this was already mentioned. We use Resumal, which stands for Rehydration Solution for Malnutrition. The standard WHO low osmolarity oral rehydration solution should not be used. So why not? Remember reductive adaptation that was lectured earlier? Diba? So that is the reason why. Resumal has a lower sodium, which contains 45 millimole of sodium, and compared to the standard ORS, which contains 75 millimole of sodium. Resumal can either, but if you don't have, kulang ng slide. But if you don't have the Resumal, you can actually make one by using the standard WHO low osmolarity oral rehydration solution. But instead of diluting it in 1 liter of water, we dilute it in 2 liters of water with added 50 grams of sugar and 40 ml of mineral mix. Okay, so if you'd ask me, where would you be able to get this Resumal? Actually, this is given by the DOH. We only have to request from them. So if Resumal is the fluid for the dehydrated conscious child, what fluid do we give for a child who is in shock? Are we going to give them plain NSS? Is it true or false? Syempre, I cannot see your answers. So the answer here is false. Some children have high serum sodium. Again, this thing or reductive adaptation. The preferred IV use for patient with shock is lactated Ringer's solution with 5% dextrose. This is the reason kanina why I told you that if the patient is hypoglycemic and in shock, we don't give anymore the 50 ml na dose. Or we could also give 0.45 saline with 5% dextrose. So how do we give the fluids? Ito siya. First and foremost, we continue breastfeeding if they are able. Introduction of F75 is usually achieved within 2 to 3 hours of restarting rehydration. I have a better slide here kasi yung kanina. So, this is how we give the fluid. So, if the severely acute patient has a severe dehydration and is conscious, we give Resumal this way, 10 ml per kilogram for the first 2 hours. And we reassess. If needed, we can still give another 5 to 10 ml per kilogram for the next 10 hours. However, when we are already here in the next 10 hours, we can alternate them giving the F75. Now, On the other side of the arrow, if the patient has decreased consciousness and or with hypovolemic shock, we give intravenous fluid at 15 ml per kilogram for the first hour. I repeat and emphasize this 15 ml per kilogram for 1 hour. We are used to giving our shock patients the well-nourished child or the normal children, we give them 20 ml per kilogram as bolus, as push. But when you have a malnourished children, you give 15 ml per kilogram. And then we reassess. If after reassessing, they are improving, but still with decreased consciousness, we can give another 15 ml per kilogram for another hour. And then we reassess them. If the patient still is in shock, we don't diagnose them anymore as having hypovolemic shock, but we suspect them as having septic shock. Okay, so that is why I have mentioned earlier that the diagnosis of hypovolemic shock is provisional. Now, in the reassessment here, if we are reassess them and the patient is already, after the first 15 ml per kilogram, if the patient is already conscious and able to feed, we can start Resomal as follows. Okay? So ito, it is very important here ha. Tandaan nyo po ito kasi hindi natin kayang lunurin yung mga bata. And next, how do we treatment of patient with nutritional edema? If with watery diarrhea and with clinical deterioration, we replace fluid loss with 30 ml Resomal per episode of watery stool, and the fluid management of hypovolemia for child with edema is the same as the treatment for septic shock. How do we treat septic shock? We give oxygen, antibiotics, prevent hypoglycemia, hypothermia, and for the conscious patient, we should start on F75. And of course, keep physical disturbance of the child to the minimum required to deliver the emergency care. If there is a decreased level of consciousness due to poor cerebral perfusion, we could give whole blood transfusion at 10 ml per kilogram or intravenous rehydration for 10 ml per kilogram in 1 hour. So I repeat, the child that is marasmic, 15 ml per kilogram in 1 hour. For the child who has nutritional edema, if needed lang talaga, we could give them 10 ml per kilogram per hour. But if not, we could give the 30 ml Resomal per episode of watery stool. And if we are going to give 10 ml per kilogram per hour, we monitor them every 10 minutes for signs of clinical changes. Monitoring during rehydration. Remember, some children have abnormal pathophysiology. They have reduced function of the cardiac, renal, and abnormal cardiovascular systems. They have abnormal responses to an increase in fluid load that may lead to heart failure. Avoid diuretics, please. Just avoid overhydration. And the aim here is rehydration to restore pre-diarrhea weight or no more than 5% of the child's weight. So how do we monitor during rehydration? I think sinasabi ko kanina, we monitor the weight. Matoxic, pero we need this. We monitor the weight every 30 to 60 minutes. If the patient is having weight gain with clinical improvement, continue to target weight and start F75. But if they have weight gain and there is no clinical improvement, stop all rehydration fluids and diagnose with septic shock. However, if the weight is stable, may increase Resomal by 5 ml per kilogram. If the patient have weight loss, may increase Resomal by 10 ml per kilogram per hour. And I would like to overemphasize this. We reassess, and record. We weigh the patient. We check the vital signs. We hear heart sounds. We check for the heart sounds. We observe for respiratory distress. We observe for continuous vomiting or diarrhea. We assess the costal margin of the liver. Check if there is jugular venous distension. Check the urine output. and the color of the urine. Immediately stop rehydration when target weight for rehydration is achieved, there is development of edema, there is development of complications, and there is an increase in respiratory rate of 5 breaths per minute, increase in heart rate of 25 beats or more, development of grunting, development of rust, crepitations, gallop. Okay, so in summary, children with SAM may not manifest the severity of their true illness. Hypothermia and hypoglycemia mark a serious infection. Some children with medical complications are treated with antibiotics. Dehydration is best treated with Resomar. IV fluids for rehydration should be administered with caution. The management of dehydration or shock between the severely wasted and those with nutritional edema is different, very much different. And early reestablishment of oral feeding is desired among some children with medical complications. Okay, with that, I say thank you very much for listening.